So, imagine a shattered femur in the trauma bay.
Right.
It's just a terrifying, chaotic, high-energy injury. I mean, you look at the x-ray and it looks like a bomb went off inside the thigh.
Oh, absolutely. It's a mess.
But the crazy thing is, at the microscopic level, the body doesn't panic at all. It doesn't, invent some frantic makeshift way to glue itself back together. It just calmly opens this ancient 9-month-old file on its hard drive, literally the exact same biological blueprint it used to build that leg in the womb, and it just hits execute.
Yeah, it really is genuinely one of the most profound phenomena in human biology. A bone doesn't just heal by forming a scar, the way skin or muscle does. It literally regenerates. I mean, it undergoes complete reconstitution of its original embryonic tissue.
Welcome to this deep dive into the biological principles of fracture healing and bone grafting. And if you are listening to this right now, we know exactly who you are.
We do.
You are an orthopedic surgeon in training. You are staring down the barrel of the FRCS trauma and orthopedics exams. You might be driving home from a grueling on-call shift, or maybe you're doing chores around the house, just trying to squeeze in some high-yield revision where you can't actually sit down and stare at a textbook or a screen.
Which is exactly why we have engineered this session specifically for your ears. You do not need to take notes. You don't need to look at any diagrams. You just need to listen.
Exactly. Our mission today is total mastery of fracture biology for the exam. I will be your guide, driving the pace, asking the classic candidate-style questions, throwing in some mental shortcuts, and, frankly, pushing back when the biology gets confusing. Because if I'm confused, you might be too.
And I'll be here to unpack the rigorous science behind it all. Because, well, in the exam, memorizing lists will only get you so far. The examiners want to see that you understand the why and the how. So we are going to explore the underlying causality of these biological rules. And because we know you are distracted, here is our promise to you. Every critical number, every list, and every key exam discriminator will be stated twice. We will loop back to them naturally in the conversation to ensure they are practically hardwired into your memory by the time your commute is over.
That's the guarantee. So let's set the foundation. There are two big overarching ideas that govern this entire topic. If you can internalize these two concepts, you won't need to memorize 1,000 separate facts because, honestly, everything else will just organically and logically flow from them. So what is the first big idea?
The first core narrative through line is exactly what you mentioned in the opening. A healing fracture replays embryology.
Okay, let's unpack that. I mean, I've seen it on the wards, but what does replaying embryology actually mean for a candidate sitting right in front of an examiner?
It means the chronological sequence of tissues that form in a fracture gap is identical, literally identical to how the fetal skeleton forms. When you were an embryo, your long bones didn't start as hard, mineralized tissue.
Right, they were soft.
Exactly. They started as soft cartilage models. The body built a cartilage template first, and then it slowly, meticulously replaced that cartilage with mature bone.
So the cartilage is essentially the scaffolding.
Yes, and a fracture callus does the exact same thing. It builds a cartilage bridge across the break and then replaces it with bone. If you understand how a baby's skeleton forms, you already possess the blueprint for how a fracture callus forms.
Okay, so the body has a factory reset mode, replay the embryo. That's big idea number one. What is the second big idea?
The second big idea is that the mechanical environment acts as destiny.
Mechanical environment, meaning the actual physical forces at play inside the patient's leg?
Precisely. We're talking about two highly specific environmental factors at the fracture site. First, strain, which is a biomechanical measure of how much the fracture gap is actually moving. And second, oxygen tension, which is a biochemical measure of how much blood flow is reaching that gap.
So strain and oxygen.
Together, strain and oxygen act as absolute biological destiny. They don't just influence the healing, they dictate exactly which type of tissue is allowed to form and survive in that space.
Mechanics is destiny at the fracture site. Okay, so if we replay the embryo and we let mechanics choose the tissue, we have our roadmap. Let's trace that roadmap chronologically. If the bone is replaying the embryo, I really want to know the exact chronological stages it goes through to pull this off.
We're talking about secondary bone healing here. This is the classic natural pathway that most fractures take when they heal with a callus, and it progresses through 4 overlapping stages.
4 stages. Let's break them down, and I want to know exactly what is happening at the cellular level in each one.
All right, stage 1 is hematoma and inflammation. The moment the bone breaks, blood vessels within the bone and the surrounding periosteum rupture. It bleeds profusely. a clot forms, creating a fracture or hematoma. Now, the old way of thinking was that this is just a static lump of dead blood acting as a plug.
Right, just like a scab.
But it is so much more than a scab. It is a highly active, aggressively signaling biochemical soup. Because the blood supply is severed, the cells inside that clot are starved of oxygen. They undergo necrosis.
They just die.
Yeah, they die. And that cell death triggers a massive inflammatory cascade. Macrophages and platelets rush into the clot and start dumping massive amounts of signaling proteins, cytokines, and growth factors into the environment.
So the trauma itself sounds the alarm, and the dead tissue is literally what summons the repair crew. Okay, stage 1 is hematoma and inflammation. What happens next?
Stage 2 is the soft callus. This is the cartilage phase. Those chemical alarms from the hematoma recruit unspecialized stem cells to the area. But remember, the environment is unstable and poorly oxygenated. So following that embryo blueprint, those stem cells differentiate into chondrocytes, cartilage cells.
Oh, wow.
Yeah, they start laying down a rubbery, flexible bridge of cartilage across the gap.
Replaying the embryo. Makes sense. Stage 2 is the soft callus. So what is stage 3?
Stage 3 is the hard callus. As new blood vessels finally start to penetrate that rubbery, soft callus, bringing fresh oxygen, the cartilage begins to mineralize. It gets calcified, and then osteoblasts arrive and start replacing that calcified cartilage with woven bone.
Woven bone. Why exactly is it called woven?
Because it is structurally disorganized. The collagen fibers are laid down rapidly in a random, crisscrossing, woven pattern. It's immature bone, it's bulky, it's messy, but it is hard. It successfully bridges the gap with mineralized tissue.
So we go from a flexible cartilage bridge to a rigid woven bone bridge. Stage 3 is the hard callus.
Which brings us to the final act. Stage 4 is remodeling. The body hates inefficiency. That bulky hard callus is a massive waste of metabolic energy to maintain, and mechanically it's just not optimized. So over months to years, osteoclasts come in and eat away the disorganized woven bone, while osteoblasts meticulously replace it with highly organized, structurally sound lamellar bone.
Lamellar bone. The finished product.
Yes. The collagen fibers in lamellar bone are perfectly aligned in parallel sheets lamellae, and they orient themselves perfectly along the lines of mechanical stress, according to Wolff's law.
Okay, let's lock this foundational sequence in. I want to make sure I have this straight for the exam. The 4 overlapping stages of secondary healing are 1. Hematoma and inflammation. 2. The soft callus, which is cartilage. 3. The hard callus, which is woven bone. And 4. Remodeling, which gives us organized lamellar bone. Let's do that one more time.
That is the exact sequence. Let's repeat it. 1. Hematoma and inflammation. 2. Soft callus. 3. Hard callus. 4. Remodeling.
Now, we keep using the phrase secondary healing. I want to contrast this with primary healing. Let's use an analogy here for the listeners who, have seen this in the trauma bay 100 times, but just need a mental model for the exam. Imagine a broken, collapsed bridge over a river.
A structural failure.
Right. Secondary healing is like a construction crew looking at that shattered bridge and deciding, well, the gap is too messy. We can't just glue this specific crack back together. So instead, they build a massive temporary scaffolding entirely encompassing the broken section. A huge, bulky cage of steel and wood to support the whole area while they rebuild the inside. That temporary, bulky scaffolding is the callus.
That's an excellent way to visualize it. Secondary bone healing relies entirely on that external callus formation. And here is the absolutely critical mechanical rule for the exam. Secondary healing occurs in an environment of relative stability.
Relative stability. I want to push back on that word, relative. I mean, what does that actually mean clinically? It's not completely floppy, but it's not totally locked.
Exactly. Think of the treatments that result in secondary healing. A patient in a plaster cast, or a tibia fixed with an intramedullary nail, or a femur fixed with a bridging plate. These implants hold the bone in a generally good, aligned position, that's the stability, but they still allow a tiny microscopic amount of motion when the patient puts weight on the limb.
So the bone still feels the load.
Yes, and that micromotion is not a complication, it is a biological requirement. Callus loves a little motion. If you don't have that slight mechanical stimulation, the cartilage soft callus won't form robustly.
So just to double down on that concept. Secondary healing relies on relative stability, meaning callus loves a little motion. Let's hit that again.
Secondary healing occurs with relative stability. Callus loves a little motion.
Okay, so if that massive scaffolding approach is secondary healing, what is primary healing?
Primary healing, often called direct healing in the literature, is the exact opposite mechanical environment. Going back to your bridge analogy, primary healing is like having two perfectly flush, razor-sharp edges of the broken bridge. You push them so tightly together and you bolt them down with such heavy, rigid steel plates that absolutely nothing can move.
Zero motion.
Absolute stability. In orthopedics, we achieve this through open reduction and internal fixation using rigid compression plates. The surgeon anatomically reduces the fracture, matching the puzzle pieces perfectly, and uses lag screws and plates to squeeze the bone ends together under massive compression.
So there is virtually no movement, and crucially, there is no gap.
Precisely. No gap, no motion.
But wait, if there is no gap and no motion, how does the bone actually heal? It can't build a massive cartilage scaffolding if there is literally no physical room for it, right?
It doesn't, and that is the key discriminator you will be tested on. In primary healing, there is no visible callus, zero. If you look at an X-ray of a perfectly compression-plated fracture at 6 weeks, you won't see a big white cloud of new bone.
So how does the crack disappear?
The bone heals directly across the microscopic fracture line using something called cutting cones.
Cutting cones. Explain how a cutting cone actually works mechanically.
Imagine a microscopic tunnel boring machine. A cutting cone is a specialized, coordinated team of cells. At the very front of the cone are osteoclasts, the cells that dissolve and eat away dead bone. They physically bore a tiny cylindrical tunnel directly across the tight fracture line, moving from one side of the crack to the other.
So they are drilling a microscopic shaft straight through the fault line.
Exactly. And directly behind the osteoclast, inside that newly drilled tunnel, trailing right behind them, are the osteoblasts, the bone builders.
So as the osteoclasts drill the hole, the osteoblasts are right there paving it with fresh bone, just sewing the two ends together.
It's an incredibly aggressive, efficient process. But here is the biological catch and why it requires absolute stability. Those cutting cones contain incredibly fragile new capillary blood vessels to keep the cells alive. If the fracture gap shifts even a fraction of a millimeter while that tunnel is being bored,
it acts like a guillotine. It would shear the cutting cone and the blood vessel right in half.
Exactly. The process fails immediately. That is why primary healing demands complete rigidity. Let's repeat those exact parameters for the exam. Primary or direct healing occurs with absolute stability. There is no movement, no gap, and crucially, no visible callus. Healing is done directly by cutting cones.
Let me lock that in. Primary healing requires absolute stability, no movement, no gap, and no visible callus. The healing mechanism is direct, utilizing cutting cones. Let's make sure we double repeat that.
Okay.
Primary healing needs absolute stability, no movement, no gap, no visible callus, and it heals by cutting cones.
Excellent.
So if you only remember one thing from this first stage of our discussion, secondary healing progresses through hematoma, soft callus, hard callus, and remodeling, and it demands a little motion. Primary healing demands absolute rigidity and heals via cutting cones with absolutely no callus.
Spot on. Now, whether you are building a massive external scaffolding or drilling microscopic internal tunnels, there is one universal truth of any construction site. You cannot build anything without supply lines.
Right, you need oxygen, you need nutrients, you need a highway for the cells to arrive. Which brings us to the vascularity of the fracture site. I know examiners love testing vascular territories, primarily because as surgeons, we are constantly operating around and sometimes destroying these very blood vessels.
It is arguably the most clinically relevant biology you will learn. You have to memorize the exact fractions of the dual blood supply in a normal long bone, like the femur or the tibia.
Okay, map it out for me. Where is the blood actually coming from?
Let's start from the inside out. The inner two-thirds of the bone's cortex is supplied by the nutrient artery. This is a major vessel that physically pierces the outer bone, enters the central medullary canal, and branches out to feed the bone from the inside. We call this the endosteal supply.
The inner two-thirds is the nutrient artery, the endosteal supply.
The outer one-third of the cortex is supplied by periosteal vessels. These are tiny branching blood vessels coming from the periosteum, that thin, tough, fibrous membrane wrapped around the outside of the bone.
Okay, so the inner two-thirds is the nutrient artery. The outer one-third is the periosteal vessels. Let's make sure we've double repeated those territories for the listeners driving right now. The inner two-thirds of the cortex is fed by the nutrient artery. The outer one-third is fed by the periosteal vessels.
The inner two-thirds is the nutrient artery. The outer one-third is the periosteal vessels. Now, here is where the exam trap is waiting for you.
Okay, what's the trap?
A candidate might logically think, well, the bone has two blood supplies. That's fantastic redundancy. If I damage the inside one, the outside one will just dilate, take over, and feed the whole bone.
Right, like collateral circulation in the heart.
Wrong. They do not back each other up in that way under normal circumstances. The flow is centrifugal. It moves from the inside out. The periosteal supply on the outside simply cannot penetrate deeply enough, nor does it have the pressure to cover the inner two-thirds if the endosteal supply is abruptly lost.
Okay, I have to push back on this with a real-world scenario, because we literally just talked about secondary healing and intramedullary nailing. Let's say a polytrauma patient comes in with a mid-shaft femur fracture. The standard of care is often to take a massive metal reamer, push it straight down the central medullary canal, bore it out to make room, and hammer a thick titanium nail down the center. If the inner two-thirds of the bone is supplied by that nutrient artery inside the canal, what happens when we run a reamer down it? Aren't we obliterating the very blood supply we need?
You are completely destroying it. Reamed intramedullary nailing acutely destroys the entire endosteal blood supply. You strip the canal bare.
That sounds like surgical sabotage. I mean, how on earth does the inner two-thirds of the bone survive, let alone heal the fracture?
It survives because bone is highly dynamic. Animal studies, particularly in sheep models, have mapped this out perfectly for us. Acutely, after reaming, that inner cortex is dead. It is ischemic. But the body responds by massively upregulating the periosteal blood supply on the outside. The outer vessels actually reverse their flow, pushing blood inward to try and keep the cortex alive.
Wow. So the peristeme tries to run a rescue mission.
It does, but it takes time. The endosteal blood supply inside the canal does eventually regenerate. New vessels grow back around the metal nail. But the critical number you need for the exam is how long that takes. The endosteal supply takes roughly 120 days to recover after reaming.
120 days, 4 months. So the inner bone is essentially struggling for 4 months.
Yes, and this physiological reality is the exact basis for the classic reamed versus unreamed nail debate in orthopedics. Reaming gives you a thicker, stronger nail and creates local bone graft from the reamings, but it sacrifices the inner blood supply for 120 days. Unreamed nails preserve more blood supply, but are mechanically weaker.
That is a brilliant way to understand the debate. The biology dictates the surgical compromise. Okay, so that's the spatial blood supply. What about the timing? How does the overall volume of blood flow to a fracture site behave over time?
It follows a very specific physiological curve. At the exact instant of the trauma, blood flow drops precipitously. Vessels are torn, pressure drops, the hematoma forms.
Acute ischemia.
Yes. But then, the inflammatory cascade triggers angiogenesis, the sprouting of thousands of new capillary blood vessels. The surrounding soft tissue envelope floods the area with blood. This creates a massive hyperemic surge.
A flood of blood to the site. When does that peak?
The exam answer is precisely at 2 weeks post-injury. That 2-week peak of hyperemic blood flow is the biological engine driving the massive cellular proliferation of the soft callus phase.
Blood flow peaks at 2 weeks. Let me double repeat that. Following a fracture, blood flow initially drops, but then hits a massive hyperemic peak at exactly 2 weeks. Let's say it again.
Blood flow drops instantly and peaks at 2 weeks.
Now, in our big ideas at the start, you mentioned oxygen tension. How does this blood flow curve tie into the actual oxygen levels the cells are experiencing in that fracture gap?
Think about that initial hematoma stage. The vessels are severed, the flow is dropped. That central clot is essentially a circulatory dead zone early on. Therefore, the local microenvironment inside that fracture gap is severely hypoxic. It is very low in oxygen.
Okay, low oxygen. Why is that biologically significant?
Because of our second big idea. The environment dictates the tissue. Stem cells are highly sensitive to oxygen levels. When an unspecialized stem cell finds itself in a low oxygen hypoxic environment, it biochemically shifts its metabolism to favor the formation of cartilage.
Ah, that is the missing link. That explains exactly why stage 2 of secondary healing is the soft cartilage callus. The body isn't randomly deciding to build cartilage first. It is being biologically forced to build cartilage because the initial low oxygen tension won't support the high metabolic demands of building mature bone right away.
You've nailed it. Cartilage isn't a vascular tissue. It is designed to survive in low oxygen. Bone requires high oxygen. The environment dictates the tissue sequence.
That is incredibly satisfying to understand. So, if you only remember one thing from this segment on vascularity, the nutrient artery feeds the inner two-thirds, the periosteum feeds the outer third. Reaming kills that endosteal supply for 120 days. Blood flow peaks at 2 weeks. And an initial low oxygen environment is what forces the body to make cartilage.
Which perfectly transitions us into the absolute mechanical heart of fracture biology. We just established that oxygen dictates tissue, but oxygen does not act in a vacuum. It interacts simultaneously with mechanical force.
Right. We need to quantify exactly how much movement dictates which tissue appears. We are talking about Perren's strain theory. Stefan Perren and the Swiss AO Foundation. This is holy text for orthopedic exams, but I find the concept of strain gets very muddy. What exactly is strain in a biological context?
Let's strip away the complex physics. Strain, simply put, is a measure of deformation. It is how much a material stretches or compresses when you apply a force to it.
Okay.
Specifically, for a healing fracture, strain is defined mathematically as the change in the length of the fracture gap, divided by the original length of the fracture gap, expressed as a percentage.
Let me visualize that. If a patient has a fracture with a gap of exactly 1 millimeter, and when they step on their leg, the bone shifts, and that gap stretches to become 2 millimeters wide, it has changed by 1 millimeter. So 1 millimeter change divided by a 1 millimeter original gap, that is 100% strain.
Exactly. The gap just stretched by 100% of its original size.
Okay, the math is simple, but what was Perren's actual biological breakthrough? Why does this percentage matter?
Perren's profound insight was observing that different biological tissues have radically different physical breaking points. His theory states that a specific tissue, whether it's blood clot, cartilage, or bone, can only form and survive in an environment where it can physically tolerate the prevailing strain. If the fracture gap stretches more than a specific tissue can handle, that tissue will literally tear apart at the cellular level. It cannot exist there.
Okay, I want to use an analogy here because visualizing this is crucial for the exam. Think about building a structural bridge, but you have 3 different materials to choose from. First, imagine the early granulation tissue, that initial messy tissue that replaces the hematoma. Imagine granulation tissue as a thick, heavy-duty, stretchy rubber band.
A rubber band.
Yes, you can take a rubber band, you can pull it, you can stretch it enormously, it deforms massively, but it doesn't break. It just bounces back. It survives massive pulling.
That is the perfect mechanical model for granulation tissue. It is incredibly floppy, disorganized, and highly tolerant of severe deformation.
Now contrast that rubber band with lamellar bone, the mature, finished bone. Imagine lamellar bone as a dry, uncooked stick of pasta, like spaghetti. It is incredibly strong. If you push straight down on it, it can bear a lot of compressive weight. But if you try to bend or stretch that dry pasta, even a microscopic fraction of an inch, what happens? It snaps instantly.
It shatters. Rubber bands and dry pasta. Now, let's attach the critical exam numbers to those materials. You must have these committed to memory. Granulation tissue, your rubber band tolerates up to 100% strain. It can literally double in length without tearing. Lamellar bone, your dry pasta, tolerates only 2% strain. Anything more than 2% stretch, and the microscopic hydroxyapatite crystals of the bone will shatter.
Granulation tissue 100%, lamellar bone 2%. Let's double repeat those thresholds. Granulation tissue tolerates 100% strain. Lamellar bone tolerates only a tiny 2% strain. One more time for the people in the back.
Granulation tissue tolerates 100% strain. Lamellar bone tolerates only 2% strain.
Now wait. I'm struggling with the logic here. If a fresh fracture is highly unstable, say it's moving a lot, and the strain is at 50%, how does the dry pasta ever get built? If bone can only survive 2% strain, how does it ever manage to form in a moving gap without constantly shattering?
This is the genius of the callus.
Oh.
It steps its way down.
Right.
It is a biomechanical cascade. When the fracture is fresh and moving wildly, the strain is high. So the only tissue that can physically survive there is the rubber band. The granulation tissue forms.
Because it can handle the 100% stretching.
Right. But as that granulation tissue fills the gap, it acts like a very mild, sticky glue. It slightly stiffens the environment. The movement decreases just a bit. The strain drops.
Okay.
As the strain drops below 10%, the environment is now safe enough for cartilage to survive. Cartilage is stiffer than a rubber band, but more flexible than bone. So the body replaces the granulation tissue with a massive cartilage soft callus.
And that massive lump of cartilage acts like a heavy-duty physical shock absorber.
Exactly. The sheer bulk of the cartilage callus dramatically stiffens the fracture gap. It stabilizes the whole area, resisting the bending forces until the movement is reduced to microscopic levels. The cartilage callus mechanically forces the strain to drop below that critical 2% threshold.
And once the strain is finally suppressed below 2%, well, now the environment is finally calm enough for the dry pasta. It is safe for osteoblasts to lay down hard bone without it shattering.
You've got it. The early flexible tissues exist purely to physically stabilize the gap so the final brittle tissue can survive.
That is genuinely incredible. The biology uses physical mechanics to bootstrap its way to stability.
Okay, so we've talked about oxygen earlier, and now we have strain. Let's combine them into the ultimate exam rule, the combinations that examiners test constantly.
This is a guaranteed multiple-choice question, the environmental rule for tissue differentiation based on strain and oxygen. Let's start with the pathological outcome. What happens if you have high strain, too much movement combined with low oxygen?
High strain plus low oxygen, what forms? You are going to get cartilage. Or worse, just fibrous scar tissue.
High strain and low oxygen yields cartilage or fibrous tissue.
Yes, and clinically, if the fracture stays stuck in that state, if the surgeon's fixation is too loose and the blood supply is ruined, that is exactly the recipe for a non-union. The bone refuses to heal, the dry pasta can never form, and you are left with a floppy, fibrous pseudojoint where solid bone should be.
But what is the winning combination? What does the bone actually want in order to heal properly?
Woven bone forms in an environment of low strain and high oxygen tension. That is the phrase the examiners are looking for. Low strain and high oxygen.
Low strain and high oxygen equals woven bone. Let's repeat that winning combination twice because it is the linchpin of fracture biology. Woven bone forms in conditions of low strain and high oxygen tension. Again,
Woven bone demands low strain and high oxygen tension. Conversely, high strain combined with low oxygen favors cartilage or fibrous tissue.
so if you only remember one thing from Perren's brilliant theory, granulation tissue acts like a rubber band tolerating 100% strain, while bone acts like dry pasta tolerating only 2% strain. Therefore, bone can only form in low strain with high oxygen, while cartilage forms in higher strain with low oxygen.
Perfectly stated.
Okay, we are about halfway through our core biological principles, which means it is time for our first mid-episode recap. We know you are driving, we know you can't look at notes, so we are going to do a rapid-fire conversational pit stop to consolidate this macrobiology before we zoom in microscopically. I'm going to run through the 3 massive takeaways.
I am ready. Let's consolidate.
Recap point 1. We have 2 fundamental ways to heal a bone. Secondary healing uses a massive temporary scaffolding progressing through hematoma, soft cartilage callus, hard-woven bone callus, and lamellar remodeling. It requires relative stability, meaning the callus physically relies on a little micromotion.
And primary healing is the opposite.
Exactly. Primary requires absolute rigidity, absolute compression, no gap, and heals directly via cellular cutting cones, showing 0 visible callus on an X-ray.
Excellent. The macroscopic differences.
Recap point 2, vascularity. The nutrient artery feeds the inner 2/3 of the cortex. The periosteum feeds the outer third. These 2 systems do not effectively back each other up. Therefore, hammering an intramedullary reamer down the canal obliterates that endosteal supply for 120 days.
The plunning of the bone. Spot on. And regarding timing.
Overall, blood flow drops acutely, then hits a massive hyperemic peak at exactly 2 Rics. Recap point 3, Perren strain theory and the oxygen rule. The body picks the tissue purely based on mechanical survival.
Right. Granulation tissue tolerates 100% strain. Lamellar bone tolerates only 2% strain.
Therefore, to get woven bone to form, it demands a calm, well-fed environment, low strain, and high oxygen tension.
Replay the embryo, let mechanics choose the tissue. That is the perfect summary of the macrobiology.
Okay, deep breath. We have established the macroscopic mechanical rules. We know how the physical environment dictates what tissue forms. Now, I want to take a microscope and zoom all the way down to the molecular level. I want to look at the exact proteins and chemical signals the body is synthesizing to actually build that tissue.
Let's do it. We are moving from biomechanics to biochemistry.
And I want to guide this directly toward the exam facts. When we talk about the structural building blocks of bone and cartilage, we are primarily talking about collagen. But there are many different types of collagen, and the examiners love to test candidates on the exact chronological sequence of which collagen appears when. They also love to throw in minor collagens as distractors in multiple choice questions.
It can feel like a random list of Roman numerals, but it is actually highly intuitive if you just keep our first big idea in mind. Replay the embryo. Let's logically deduce the sequence. What is the chronological sequence of tissues in a secondary healing callus?
Well, we established that. It's cartilage first, then bone.
Exactly. Now, you just need to know which collagen builds which tissue. Cartilage is primarily constructed out of type 2 collagen. Therefore, following the embryo logic, type 2 collagen production must be the highest in the early stages of healing, specifically peaking in the first 2 weeks, when that soft cartilage callus is being built.
Okay, type 2 collagen is early because cartilage is early.
Then, as that cartilage mineralizes and is replaced by the hard callus, the tissue changes to bone, and bone is primarily constructed out of type I collagen. Therefore, Type I collagen production peaks later in the healing process.
That makes perfect logical sense. The collagen sequence perfectly matches the tissue sequence. Type 2 collagen early, type I collagen late. Let's repeat that sequence twice for the exam. Type 2 collagen is highest early on because it constructs the cartilage. Type I collagen peaks later because it constructs the bone. Type 2 early, type I late.
Type 2 collagen peaks early for the cartilage phase. Type I collagen peaks later for the bone phase. Now, as you mentioned, the examiners won't just ask about I and II. They will use the minor collagens as distractors to see if you really know your biochemistry. You don't need a PhD in them, but you must recognize their basic functions.
Okay, hit me with the minor collagens. What do I actually need to recognize?
Let's look at type 3 collagen first. Remember, we talked about the periosteum, the outer fibrous lining of the bone. Very early in the healing process, type 3 collagen is laid down rapidly as a kind of preliminary periosteal scaffold. It provides a rough, temporary framework for early osteoprogenitor cells to migrate along, and for those new capillary blood vessels to grow into during angiogenesis.
Think of type 3 as the very early temporary periosteal scaffolding. Got it. What else?
Then there is type IX collagen. Type IX has a very specific structural job. It physically binds to the type 2 collagen in the cartilage and cross-links the fibrils. It adds essential mechanical stability to the cartilage, making it tougher and more resilient to shear forces.
So type IX cross-links and stabilizes type 2 cartilage.
Yes. And finally, you might see types V and Azalev in an exam option. Their role is largely regulatory rather than structural. They sit inside the core of the collagen fibers and help regulate the physical diameter of the growing fibrils, and they dictate the 3D orientation of the main collagen network, ensuring everything is aligned properly for load bearing.
Let's do a double repetition of those minor collagens because they are prime multiple choice fodder. Type 3 is the early periosteal scaffold for migrating cells and capillaries. Type IX crosslinks and adds mechanical stability to type 2 cartilage. Types V and XO regulate fibril diameter and spatial orientation. One more time.
Type 3 is the early periosteal scaffold. Type IX provides mechanical stability to type 2. Types V and XI regulate fibril growth and orientation.
Excellent. So that covers the structural proteins, the bricks and mortar. But what about the foreman on this construction site?
Right.
The chemical signals actively shouting the orders to the cells. Let's talk about growth factors.
The growth factors are the crucial orchestrators. The single most important overarching regulatory molecule you must know is TGF-beta, transforming growth factor beta.
TGF-beta, what is its exact role?
It is the master conductor of the callus symphony. TGF-beta is synthesized by platelets in the initial hematoma and later by osteoblasts and chondrocytes. It is responsible for regulating massive cellular proliferation, driving both the cartilage formation and the subsequent bone formation within the callus. It controls the whole timeline. But here is the major exam trap alert regarding TGF-beta.
We love an exam trap. What is the clinical catch?
Researchers have identified a very specific, testable clinical correlation. Because TGF-beta is so central to healing, the levels of circulating TGF-beta in a patient's systemic blood serum can act as a biomarker. Specifically, measuring circulating TGF-beta levels is a strong predictor of delayed healing and non-union.
Wait, really? So if a patient has a tibial fracture and you draw their blood from their arm, the amount of TGF-beta floating around systemically can tell you if that tibia is going to fail to heal.
Exactly. The pathological loop is fascinating. If the mechanical environment is poor, say, high strain, the local cells keep pumping out more and more TGF-beta, desperately trying to force the callus to stabilize. But it's failing. So the TGF-beta spills over into the systemic circulation. High circulating levels flag that the local site is struggling. It's a highly testable trivia fact. Circulating TGF-beta levels are a predictor of non-union risk.
Let's repeat that twice because it sounds exactly like one of those rogue questions on a basic science paper. Circulating TGF-beta levels in the blood are a predictor of delayed healing or non-union. Let's say it again.
High circulating TGF-beta levels predict delayed healing and non-union risk.
Are there any other specific growth factors we need to memorize?
The other major family you must know is the BMP's bone morphogenetic proteins. These are part of the TGF-beta superfamily, but they are incredibly powerful in their own right. They are strongly osteoinductive.
Osteoinductive. We will define that rigorously when we get to bone grafts, but briefly, what does that mean biochemically?
Osteoinductive means these proteins have the active power to induce or persuade unspecialized mesenchymal stem cells to turn specifically into bone-forming osteoblasts. They don't just support bone growth, they actively drive naive stem cells down the bone-forming pathway.
They literally recruit the workers and hand them a blueprint for bone. Amazing. So if you only remember one thing from this molecular segment, type 2 collagen peaks first to build the cartilage, and type I collagen peaks later to build the bone. Furthermore, TGF-beta is the master regulator, and high circulating levels in the blood act as a red flag for non-union risk.
Spot on. Now that we've seen how the molecular proteins are synthesized and regulated, let's zoom back out slightly to the tissue architecture level. We need to formalize the terminology of the processes we've been describing.
Right. We keep using terms like cartilage template. Let's formally define these ossification terms because examiners love to test the contrast between them. They especially love setting up odd one-out questions here.
Let's define the two distinct pathways the body uses to turn primitive tissue into mature bone. The first pathway is endochondral ossification. If we break down the word, endo means inside, chondral means cartilage. This is the process of bone forming upon a pre-existing cartilage template. You lay down cartilage first, it calcifies, and then you replace it with bone.
Replay the embryo.
Exactly. Most of the embryonic skeleton forms via endochondral ossification. Longitudinal growth at the phases of the growth plates in children happens this way. And crucially, as we've discussed extensively, a fracture callus forms this way. Callus is endochondral.
Okay, endochondral means cartilage first, then bone. What is the second pathway?
The second pathway is intramembranous ossification. This is a much more direct, accelerated route. In intramembranous ossification, there is absolutely no cartilage step. Zero. Bone is laid down directly by osteoblasts into a primitive fibrous membrane, or directly into a gap without ever forming a cartilage intermediate.
No cartilage middleman. Just straight from stem cell to bone. Let's double repeat those formal definitions. Endochondral ossification is bone forming on a cartilage template, cartilage first, then bone. Intramembranous ossification is bone laid down directly by osteoblasts with absolutely no cartilage step.
Endochondral ossification requires a cartilage template. Intramembranous ossification lays down bone directly, skipping the cartilage phase entirely. Now, here's exactly where the examiners will set the trap.
I am ready. Give me the odd one out scenario.
They will give you a list of biological processes and a multiple choice question and ask which one heals via intramembranous ossification. They will list things like embryonic long bone formation, fracture callus healing, longitudinal growth plates, and then they will slip in the term distraction osteogenesis.
Distraction osteogenesis. Okay, for the listener who hasn't rotated through a limb reconstruction clinic recently, let's define that. This is the Alizarov technique. It's when a surgeon deliberately cuts a bone in half, attaches a massive external ring fixator to the leg, and then slowly, day by day, turns the struts to physically pull the two bone ends apart to lengthen a shortened limb.
Exactly. You are constantly mechanically pulling a fresh fracture gap open, roughly 1 millimeter a day. And because you are providing massive, slow, continuous tension to the healing tissues, the biology responds in a highly unique way based on the tension stress effect. Distraction osteogenesis heals entirely by intramembranous ossification.
Wait, really? It doesn't form a callus?
It does not form a cartilage callus. The constant, slow, mechanical distraction physically aligns the collagen fibers and forces the osteoblast to lay down new woven bone directly into the pulled gap, perfectly parallel to the direction of the pulling, with absolutely no cartilage intermediate step.
Wow. So by constantly pulling the gap, the mechanical tension tricks the body into skipping the cartilage phase entirely. That is a massive exam trap. Distraction osteogenesis is intramembranous, not endochondral.
Let's repeat that odd one out twice. Distraction osteogenesis heals by intramembranous ossification. New bone forms directly in the tension gap with zero cartilage.
Distraction osteogenesis heals by intramembranous ossification. New bone forms directly in the gap with no cartilage. Are there any other intramembranous traps they might throw in?
The other classic example is normal perichondrial or periosteal bone formation. When a long bone needs to get wider appositional growth, the periosteum lays down bone directly on the outside of the shaft. That is also intramembranous. But distraction osteogenesis is the most heavily tested because of its unique biomechanical mechanism.
So if you only remember one thing about ossification types, normal fracture callus is endochondral, meaning it requires a cartilage template first. But distraction osteogenesis, like an Alizarov frame, is intramembranous, meaning bone is laid down straight into the gap with absolutely no cartilage. Okay, we are going to step away from the microscopic cells entirely now and look at the macro level. We are going to look at the pure physics of the break itself. How do the external mechanics of a blow, The vector of the force hitting the leg perfectly dictate the physical shape of the resulting fracture on the X-ray.
This is a very satisfying segment of fracture biology because it relies on pure vector physics, not just rote biological memorization. It is highly logical. If you know the physics, you can look at an X-ray and reverse engineer exactly how the patient was injured.
I love logical deduction. Let's start with the fundamental golden rule of bone mechanics.
The golden rule is based on the fact that bone is an anisotropic material.
Uh,
That's a biomechanics term, meaning the material responds differently depending on the direction the force is applied. Bone is incredibly strong under compression pushing forces because of its mineral content. But the absolute truth you must memorize is that bone is inherently weakest in tension.
Tension meaning stretching forces, pulling the bone apart.
Yes. Bone can withstand a lot of crushing, but it cannot withstand much stretching. Therefore, when a bone is subjected to a bending force, it will always fail and break on the tension side first.
Okay, I have a very simple heuristic for this that I always use when looking at trauma x-rays. Imagine taking a fresh green stick from a tree and breaking it over your knee. You hold the two ends and pull them back strongly towards you. The side of the stick facing away from you, the outside of the curve, is being stretched apart. That is the tension side. The side of the stick physically touching your knee is being crunched together. That is the compression side.
Exactly. A classic three-point bending model.
And when you bend that stick far enough, where does it snap first? It never crushes on your knee first. It always tears on the outside edge first, the side being stretched. It fails in tension.
That is precisely what cortical bone does. It develops microscopic cracks on the tension side that rapidly propagate across the shaft. Let's state that golden rule twice for the listeners. Bone is weakest in tension, so a fracture always initiates on the tension side.
Bone is inherently weakest in tension, so a fracture always starts on the tension side. Now, let's use that rule to match specific forces to the specific fracture patterns they create.
First up, a transverse fracture. This is a clean break straight across the bone at a perfect 90-degree angle to the shaft. A transverse fracture is caused by a pure bending force. Imagine a perpendicular blow, like a swinging baseball bat hitting the side of a tibia perfectly straight on, with no axial load. Pure bending snaps it cleanly straight across.
Transverse equals pure bending.
Next is the spiral fracture. Think of a classic low-velocity skiing injury. The ski boot is locked into the binding, the ski catches an edge, and the skier's massive body weight twists around the planted leg. That rotational twisting force is called torsion. Torsion creates a beautiful winding spiral fracture pattern wrapping up the shaft of the bone.
Spiral equals torsion or twisting.
Then we have an oblique fracture. This is a diagonal line traversing across the bone. It is generally caused by an uneven bending force, or bending, combined with an axial load, meaning a compressive force pushing straight down the length of the bone at the exact same time it bends.
Oblique equals uneven or axial bending. But let's get to the most heavily tested, most mechanically interesting pattern, the butterfly fragment.
The butterfly fragment. This is a triangular, wedge-shaped piece of bone that completely breaks off from the main shaft during the fracture. It happens when there is a severe bending force combined with a significant axial compression force.
Okay, let's apply our green stick breaking analogy to this to understand the physics. You violently bend the bone over your knee, but you are also pushing the ends together.
Right. Let's trace the failure. Remember the golden rule? Bone fails in tension first. So the tension side, the outside of the curve being stretched, snaps cleanly. The microcrack starts there and propagates. It creates a single, clean, transverse fracture line on the tension side. But on the other side, the compression side touching your knee, the bone is being violently crushed together by the axial load.
So because it's being crushed, it doesn't snap cleanly. It crumbles under the pressure.
Exactly. The extreme compressive force causes the bone on the inside of the curve to literally crumble and shear off in two diagonal lines, creating a wedge shape. That wedge is the butterfly fragment. Therefore, the critical exam fact you must deduce is this. The butterfly fragment always sits on the compression side of the bending force.
That is brilliant. The tension side snaps cleanly because it fails first. The compression side crushes into a wedge. You can look at the x-ray, find the butterfly wedge, and know instantly which direction the leg was hit. Let's do our double repetition of those patterns. Match the force to the fracture. Transverse fracture equals pure bending. Spiral fracture equals torsion. The butterfly fragment sits on the compression side because bone always fails in tension first.
Transverse equals pure bending. Spiral equals torsion. The butterfly fragment is located on the compression side because the opposite tension side fails cleanly first.
If you only remember one thing from this macrophysics segment, make it this. Transverse equals bending, spiral equals torsion, and the butterfly fragment is always on the compression side because bone is weakest in tension.
Let's do a quick mid-episode recap too right here before we move into the applied clinical scenarios. We need to lock down the molecular and macro patterns we just covered.
Second pit stop. Let's consolidate. Recap point 1. Molecular biology. Following the embryo timeline, type 2 collagen appears early to build the initial cartilage soft callus. Type I collagen appears later to build the hard woven bone. The master regulator orchestrating this is TGF-beta, and high circulating levels of it in the systemic blood actually predict a non-union risk.
Spot on. The biochemistry is locked in.
Recap point 2. Ossification pathways. Normal fracture callus is endochondral, meaning it requires a cartilage template to form bone. But distraction osteogenesis, physically pulling a gap apart with an Ilizarov frame, is the major exam odd one out. It heals via intramembranous ossification, forming bone directly in the tension gap with absolutely zero cartilage.
Exactly. The biomechanical exception to the rule.
Recap point 3. Macrofracture patterns. Bone is fundamentally weakest in tension and fails there first. A pure bending force causes a transverse fracture. Torsion causes a spiral fracture. And a bending plus compression force creates a butterfly fragment, which always sits crumbled on the compression side.
Excellent. We have now laid a massive, rigorous foundation of biology and biomechanics. For the final phase of this deep dive, we are going to apply these exact biological rules to two highly specific, heavily tested clinical scenarios, and then we will finish with a masterclass on bone grafting.
Let's tackle the clinical scenarios. We're talking about atypical femoral fractures and heterotopic ossification. Let's start with the atypical femoral fracture. This is an incredible topic because it acts as a perfect callback to our earlier discussions on bone metabolism, specifically regarding osteoporotic patients on long-term bisphosphonate medications.
Yes, bisphosphonates are fantastic drugs for osteoporosis, but their mechanism of action is to selectively induce apoptosis cell death in osteoclasts. They suppress the osteoclasts, which effectively stops bone from being broken down and turned over. However, healthy bone requires constant turnover to repair daily microdamage. If you freeze that turnover for years, the bone matrix accumulates microcracks. It becomes densely mineralized, but incredibly brittle, like porcelain.
And that brittle bone becomes prone to a very specific type of stress fracture, the atypical femoral fracture. And we are bringing it up right now in this specific context because its exact location on the femur perfectly proves the mechanical rule we literally just learned. Bone fails in tension first.
It does.
Here is where it gets really interesting. Break down the exact location of this fracture for me.
These atypical fractures happen exclusively in the diaphysis, the main shaft of the femur. Specifically, anywhere from just below the lesser trochanter down to just above the supracondylar flare at the knee. But the diagnostic magic is in exactly where on the circumference of the bone the fracture initiates.
Where does the crack start?
It always starts at the lateral cortex, the outside edge of the femur.
Why specifically the lateral side? Why not the front or the medial side?
Think about the growth anatomical shape of the human femur. It is not a perfectly straight pillar. It has a natural, subtle anterior and lateral bow to it, curving outward. When you stand up and put weight on your legs, gravity and muscle forces act on that curve. That natural bow means the medial side, the inside curve, is physically under compression. But the lateral side, the outside of the curve, is constantly under mechanical tension. It is constantly being slightly stretched every time you take a step.
Oh, man. So because the lateral cortex is the tension side of the bowed femur, and we know the golden rule that bone is always weakest in tension, that is exactly where the brittle, bisphosphonate-laden bone begins to microscopically fail.
Exactly. The biomechanics perfectly predict the pathology. The microcracks accumulate on the tension side. The fracture starts on the lateral tension side cortex. Now, for the exam, you cannot just say lateral fracture. You need to know the specific diagnostic criteria established by the ASPMR. An atypical femoral fracture requires the location we just mentioned, plus the presence of 4 out of 5 specific radiographic and clinical features.
I know examiners love a 4 or 5 criteria list. Give me the 5 features and explain the why behind them.
Feature 1. The fracture occurs with minimal or absolutely no trauma. A patient might literally just be walking across the kitchen when the femur snaps. This proves it's a stress failure, not a traumatic one. Feature 2. The fracture line originates at the lateral cortex and is substantially transverse in its orientation. This proves it's a pure tension failure.
Okay, minimal trauma, starts lateral, and is transverse. What's next?
Feature 3. It is strictly non-comminuted, meaning it's a clean break, not shattered into multiple fragments. Brittle porcelain snaps cleanly. It doesn't crush into fragments like normal bone. Feature 4. You will see localized periosteal thickening or beaking of that lateral cortex on the X-ray.
What is the beaking?
The beaking is the body's desperate, failed attempt to heal the chronic stress fracture over months before it finally snaps. It lays down a lump of bone, a beak, trying to reinforce the cracking lateral cortex. And finally, feature 5. If it's a complete fracture all the way across the shaft, it often has a sharp medial spike. If it's an incomplete fracture, it only involves that lateral cortex.
Let me repeat those, because this is prime exam material. The 5 features are: 1, minimal trauma; 2, starts laterally and is transverse; 3, non-comminuted; 4, localized lateral periosteal thickening or beaking; and 5, complete fractures have a medial spike. Incomplete or lateral only. Let's do the double repetition.
The 5 criteria for an atypical femoral fracture: 1, minimal to no trauma; 2, starts lateral and transverse; 3, non-comminuted; 4, localized lateral beaking; 5, complete fractures exhibit a medial spike; incomplete involve the lateral cortex only.
So clinically, if you are in the ER and you identify one of these fractures on an X-ray, what is the immediate next clinical step you must take?
You must immediately X-ray the opposite, contralateral femur. Because the bisphosphonate use is systemic and the mechanical stress of walking is bilateral, these stress fractures are very frequently bilateral. The other leg might be weeks away from snapping.
Brilliant application of the biology. Okay, let's pivot to the second clinical scenario. Heterotopic ossification, commonly abbreviated as HO. What exactly is this?
Simply put, heterotopic ossification is the pathological formation of mature lamellar bone in soft tissues where bone absolutely does not belong. Usually this happens inside a muscle belly or in the soft tissues surrounding a major joint, like the hip or elbow. It is generally painless once it fully matures, but physically it acts like a massive biological doorstop. It severely stiffens the joint and can completely ruin the patient's range of motion.
What goes wrong biologically to cause the body to just mistakenly build a block of bone inside a muscle?
It is triggered by a massive systemic inflammatory response, usually related to severe catastrophic trauma. The exact cellular mechanism involves circulating humoral factors that essentially confuse local mesenchymal stem cells in the muscle, inappropriately inducing them to differentiate into osteoblasts instead of fibroblasts. There is a classic, highly specific exam vignette for this that you must recognize instantly.
Give me the classic exam setup.
If you see a question stem describing a comatose, head-injured patient in the ICU who also happens to have a hip fracture or a major joint dislocation, they are setting you up to answer a question about HO. There is a profound, albeit poorly understood, brain-bone connection where severe traumatic brain injury releases systemic factors that massively upregulate bone formation everywhere in the body.
Let's repeat that classic vignette twice. A comatose head-injured patient with a hip fracture is the classic exam setup for heterotopic ossification.
A comatose head-injured patient with an associated hip fracture or joint trauma is the classic vignette for heterotopic ossification.
What are the other major risk factors besides traumatic brain injury?
The other major systemic risk factors you must reel off are spinal cord injury, major severe burns covering a large body surface area, prolonged mechanical ventilation in the ICU, and blast amputations, specifically military scenarios where the amputation goes right through the mangled zone of the blast injury. All of these massive traumas send chaotic systemic signals that confuse the stem cells.
So if we are treating a polytrauma patient and we know they are at massive risk for developing this bone block, how do we stop it? What is the prophylaxis?
There are 3 heavily tested prophylaxis options, and you need to understand the why behind each one. The first is non-steroidal anti-inflammatory drugs, NSAIDs, and the classic specific drug tested is indomethacin.
Why indomethacin specifically?
Because HO is driven by prostaglandin-mediated inflammation. Indomethacin is a potent COX inhibitor that dramatically drops prostaglandin levels, cutting off the inflammatory signal before the stem cells get confused.
Okay, NSAIDs. What is the second option?
The second option is localized single-dose radiation therapy to the joint, usually given within 24 hours of surgery.
Wait, radiotherapy. We are talking about preventing bone healing, not treating cancer. Why radiation?
Because the initial phase of HO involves rapidly dividing rogue stem cells proliferating in the muscle. Radiation therapy selectively targets and damages the DNA of rapidly dividing cells. A low dose halts those rogue stem cells in their tracks before they can differentiate and calcify into a bone block.
That makes perfect sense. And the third prophylactic option?
The third is bisphosphonates. Since bisphosphonates halt osteoclast activity and disrupt the calcium phosphate balance, they can physically prevent the soft tissue mass from mineralizing into hard bone.
Let's do the double repetition on the prophylaxis. The three prevention options for HO are NSAIs, classically indomethacin, localized radiotherapy, and bisphosphonates.
Prophylaxis for heterotopic ossification. NSAIs like indomethacin, localized radiotherapy, or bisphosphonates.
Okay, one more clinical detail. If the prophylaxis fails, the bone forms, and the hip joint is completely locked up in a block of bone, how do we classify it, and when can we surgically fix it?
We grade the severity around the hip using the Brooker classification, which ranges from grade 1 islands of bone to grade 4, which is complete bony ankylosis blocking the joint space. As for treatment, you can surgically excise the rogue bone, but timing is everything. You must wait for the HO bone to completely mature before excising it. This usually takes many months.
Why do you have to wait? Why not cut it out immediately?
Because if you operate while the tissue is still biologically active, immature, and inflamed, the surgical trauma of cutting it out will act as a second massive inflammatory trigger. The HO will aggressively recur and explode back worse than before. You have to wait for the biological fire to burn itself out.
Wait for it to mature. Got it. So, if you only remember one thing from these clinical scenarios, atypical femoral fractures start on the lateral tension side cortex and require 4 of 5 specific radiographic criteria. Heterotopic ossification is classically seen in brain-injured patients and is proactively prevented by indomethacin, radiotherapy, or bisphosphonates.
Spot on. We have arrived at the final major biological concept of our session. We've spent an hour talking about how the body brilliantly heals itself. But what happens when the biology catastrophically fails? What if the fracture gap is too big or the blood supply is too poor and the bone simply cannot bridge the gap using its native embryological mechanics?
That is when the surgeon has to step in and play the role of the embryo. We have to artificially supply the exact biological ingredients of a healing callus to jumpstart the process. We have to perform a bone graft. And thankfully, there is an incredibly clean, logical framework for understanding bone grafts for the exam. I like to structure this as the 3 gifts a graft can give.
I like that framework. The 3 biological gifts plus 1 mechanical bonus.
Exactly. Let's use an analogy to make these technical terms stick. Think about planting a brand new section of a garden from scratch in a barren patch of dirt. To get a garden to grow, you essentially need 3 distinct things. First, you need a physical structure like a wooden trellis. You need a 3D physical matrix for the new vines to climb onto and grip. If you don't have a trellis, the vines just sit in the mud and rot. In bone grafting, that trellis is called osteoconduction.
Osteoconduction. The bone graft provides a physical, porous, 3-dimensional scaffold or matrix. It allows the patient's own native bone cells and new capillary blood vessels to physically grow into it and creep along its surface. It passively conducts the growth. This process of the host replacing the graft is often called creeping substitution.
The first gift is osteoconduction, providing the physical trellis. Now, the second thing a barren garden needs is fertilizer. You need chemical signals in the soil that shout at the dormant seeds, hey, wake up, it's time to start growing. In bone grafting, that chemical fertilizer is called osteoinduction.
Osteoinduction. This means the graft contains active biological signaling molecules. Specifically, it contains those growth factors we discussed earlier, primarily the BMP's bone morphogenetic proteins. These signals diffuse out of the graft into the surrounding host tissue, grab unspecialized stem cells, and actively induce or recruit them, forcing them to differentiate into bone-forming osteoblasts.
The second gift is osteoinduction, providing the chemical fertilizer. Finally, a garden needs the single most important thing, the actual living seeds. You can have the best trellis and the strongest fertilizer, but without living seeds, absolutely nothing grows. In bone grafting, this is called osteogenesis.
Osteogenesis. This is the ultimate biological gift. This means the graft material actually contains living, surviving osteoblasts and primitive stem cells that will directly synthesize and lay down new bone themselves. They generate new bone natively, independent of the host's cellular response.
The third gift is osteogenesis, providing the living seeds. So we have osteoconduction, the physical scaffold, osteoinduction, the chemical signal, and osteogenesis, the living cells. And what was the mechanical bonus you mentioned?
The bonus property is structural integrity. This simply means is the physical piece of graft material you are putting into the patient strong enough to bear mechanical weight immediately. A solid, thick block of cortical bone can bear the weight of a patient walking on it. A mushy paste of cells or a synthetic powder cannot.
Okay, let's do the double repetition of the three gifts and the bonus, because this framework is the absolute key to answering every single bone graft question. 1, osteoconduction, providing a physical scaffold. 2, osteoinduction, providing chemical signals to recruit host stem cells. 3, osteogenesis, providing actual living bone cells. And the bonus is structural integrity, providing immediate mechanical load-bearing strength.
1. Osteoconduction, the scaffold. 2. Osteoinduction, the signals. 3. Osteogenesis, the living cells. Bonus. Structural integrity. Now that you have the definitions locked in, the exam will ask you to grade the specific clinical types of graft based on exactly which of those gifts they offer.
Okay, let's grade them. Let's start with the absolute gold standard in orthopedics, autograft. This is taking bone from the patient's own body, usually harvesting it from the iliac crest of their pelvis, and moving it to the fracture site in their leg. What gifts does autograft give?
Autograft is the gold standard for a very specific reason. Because it is freshly harvested from the patient's own living body, it gives all three gifts perfectly. It has the physical trabecular bony matrix, so it is osteoconductive. It contains native growth factors trapped in that matrix, so it is osteoinductive. And crucially, because you just scooped it out fresh and immediately transplanted it, it is packed with living cells, so it is highly osteogenic. And if you take a thick cortical strut from the pelvis, it gives structural integrity too. Autograft gives everything.
Autograft gives all three: scaffold, signal, and living cells. Let's repeat that. Autograft gives conduction, induction, and osteogenesis. Okay, but harvesting autograft has a major downside. It physically hurts the patient. You are creating a second surgical site, which carries risks of chronic pain, infection, and nerve damage. So what if we want to avoid that and use allograft instead? This is donor bone, harvested from a human cadaver, processed, sterilized, frozen, and stored in a hospital bone bank. The classic example tested is a fresh frozen cortical allograft strut. What gifts does allograft give?
Allograft gives you the physical bony matrix, so it is highly osteoconductive, it's a great trellis, it retains many of the BMP proteins trapped inside that matrix, so it is somewhat osteoinductive. And because it is a solid piece of cortical bone, it has excellent structural integrity. But here is the massive exam discriminator. It provides absolutely no osteogenesis.
Wait, why no osteogenesis? It's human bone, isn't it?
It is human bone. But think about the processing. By the time it has been harvested from a cadaver, chemically sterilized, irradiated to kill viruses, and fresh frozen in a tissue bank for 6 months, every single cell inside that bone is entirely irrevocably dead. There are no living seeds left. Therefore, allograft is absolutely not osteogenic. Furthermore, because it contains foreign proteins, it always carries a small risk of being immunogenic, meaning the host body's immune system might mount a mild rejection response against it, delaying incorporation.
This is the ultimate exam discriminator. Let's make this crystal clear. The difference between autograft and allograft comes down to one single biological word: osteogenesis. Only autograft brings living cells to the party. Allograft provides the scaffold and the signal and the structure, but zero living cells.
Let's repeat that ultimate discriminator twice. The primary biological difference between autograft and allograft is osteogenesis. Autograft has living cells, allograft does not.
The primary discriminator between autograft and allograft is osteogenesis. Autograft provides living cells, allograft does not. Are there any other graft types we need to quickly grade for completion?
Yes, demineralized bone matrix, commonly called DBM. This is allograft cadaver bone that has been deliberately bathed in acid to dissolve away all the hard calcium and mineral content, leaving only the soft collagen and proteins behind.
Why on earth would you dissolve the hard structural part of the bone?
Because dissolving the hard mineral physically exposes all of the trapped growth factors, particularly the BMPs, making them highly accessible to the host tissue. This makes DBM highly osteoinductive. So DBM is osteoconductive, it has collagen, and heavily osteoinductive because of the exposed signals. But because you deliberately dissolved all the mineral, it has zero structural integrity. It handles like a mushy putty. And like all allograft, the cells are dead, so it has no osteogenesis.
So DBM is just a highly inductive, non-structural buddy. So if you only remember one thing about bone grafting, a graft can give a scaffold, a signal, and living cells. Autograft is the gold standard because it gives all three. Allograft gives scaffold, signal, and structure, but absolutely no living cells.
Perfectly summarized.
We have made it to the end of the deep dive material. It is time for the final challenge, the lightning round. I am going to step into the role of the ruthless FRCS examiner. I am going to rapid fire the 8 absolute highest yield questions from today's session at you. I don't want deep explanations. I want clean, plain, unhesitating, exam-ready answers. You ready?
I'm ready. Let's do it.
Question 1. Contrast the mechanical requirements and the biological presentation of primary versus secondary fracture healing.
Secondary healing requires relative motion, loves microstrain, and forms a bulky, visible callus. Primary healing requires absolute rigidity, absolute compression, forms zero visible callus, and heals directly via microscopic cutting cones.
Question 2. Describe the normal fracture blood supply territories and the specific physiological effect of intramedullary reaming.
The nutrient artery feeds the inner two-thirds. The periosteum feeds the outer third. Reaming the canal completely obliterates that endosteal supply, rendering the inner cortex ischemic for up to 120 days. Also, overall blood flow hits a massive hyperemic peak at exactly 2 weeks post-injury.
Question 3. According to Perren strain theory, what are the exact strain tolerances for granulation tissue and lamellar bone, and what is the environmental rule for forming woven bone?
Granulation tissue tolerates a massive 100% strain. Lamellar bone shatters at anything over a tiny 2% strain. The golden environmental rule is that woven bone demands an environment of low strain combined with high oxygen tension.
Question 4. What is the collagen sequence in a healing fracture callus?
Replaying the embryo, type 2 collagen peaks early to form the initial cartilage scaffold, and type I collagen peaks later as it's replaced by heart bone.
Question 5. Regarding endochondral versus intramembranous ossification, what is the classic exam odd one out and why?
Distraction osteogenesis, like an Elizarov frame. Unlike a normal callus, which uses a cartilage template, distraction osteogenesis heals via intramembranous ossification, forming woven bone straight into the tension gap with absolutely zero cartilage.
Question 6. Based on the physics of bending forces, where does the butterfly fragment sit and why?
The butterfly fragment always sits on the compression side. This is because bone is inherently weakest in tension, so the opposite tension side fails and snaps cleanly first, leaving the compression side to crumble into a wedge.
Question 7. A comatose head-injured patient with a hip fracture is at massive risk for what complication, and what are the 3 ways we prevent it?
They are at high risk for heterotopic ossification. We proactively prevent it using NSAIDs like indomethacin, localized single-dose radiotherapy, or bisphosphonates.
Final question, question 8. What is the single ultimate biological discriminator between fresh autograft and fresh frozen allograft?
Osteogenesis. Autograft contains living, active bone cells. Fresh frozen allograft contains entirely dead cells and provides zero osteogenesis.
Boom! That is the lightning round. That is the high-yield core of fracture healing.
To bring this all home, I want you to step back from the memorization for a second and look at the beautiful symmetry of what we've just discussed today. Think about that bone graft framework we just finished with. Scaffold, signal, and cells. Osteoconduction, induction, and genesis. Those are the exact 3 ingredients that the embryo used to form your skeleton in the womb. A physical cartilage template, chemical growth factors driving development, and active stem cells building the tissue. When you perform a bone graft in the operating theater, you are not inventing a new medical procedure. You are quite literally just handing the body the exact embryonic ingredients it needs and begging it to replay its original code one more time.
It is truly elegant biological engineering. It's not just carpentry with plates and screws. It's coaxing nature to remember how it was built. And that incredible interplay between physical structure and chemical signaling isn't just limited to bone. It's mirrored everywhere in the body's wiring. Which brings us to a provocative thought for you to mull over during your next study session or for the rest of your drive. How does a severed nerve cable know how to find its target muscle again? How does the microscopic architecture of a nerve sheath physically protect its electrical signals? And biologically, what happens when that architecture is crushed versus cleanly sliced? That biological engineering is exactly what we will be unpacking in our next deep dive. We will be tearing into nerve sheaths, Wallerian degeneration, injury grading, and the intricate world of the brachial plexus.
It is a phenomenal topic. Until then, keep replaying those biological rules in your head. Replay the embryo. Mechanics is destiny.
We wish you the absolute best of luck with your FRCS exam revision. Keep grinding, trust the biology, and you've got this. See you next time.
See you next time.